My dear friends, very good morning. I think all of you are very happy. In the previous classes, we discussed about the important ancient disease, that is leprosy, the tuberculosis. Now, today, what disease shall we discuss? What is the sister of tuberculosis? You are seeing on the screen, it is a spotter. By seeing this, you can identify. This is Hansen's disease. Hansen's disease. The epidemiology of leprosy we will discuss today. The epidemiology of leprosy. See this picture. This is Gandhi Prem Nivas, Leprosy Center. I think it is Titlagar or Titlagar. I think it is Titlagar. Titlagar. Now we are calling it Titlagar. It might be Titlagar. It was maintained by missionaries of charity during 1970s, 79 to 81. It is for the sake of leprosy patients. Then these people were abandoned, outcasted, not allowed to enter into the house. These people are looked down at that time. The missionaries, with the loving hand, the helping hand, the service mind, they have come and they have put these service centers. Even now, we can see the good NGOs, non-governmental organizations, voluntary organizations, Hindu Kushtu Nivaran Sangh, and this AMG in our area, Advancing the Ministries of Gospel, AMG. These people have helped the people. Even now they are helping. They are having leprosy colonies at Chengiz Khan Pet, in between Guntur and Chilkalarpet. In the hilly area, they have this colony for leprosy patients. There, depending upon their profession, the people will be engaged in the work. The lepers, that means the people with leprosy, they will be put there because they are sent out of the house by their family members. So, they stay there. The agriculturalists, the agricultural labor, those people will do the agricultural work. The weaving people, they will weave like that. Depending upon their profession, they will be given work. All the expenditure will be given by the organization, but the product of selling, the amount which we get by selling those products, that will be distributed to these people according to their work, and it will be sent to their families for the maintenance of the families. That is just self-sustainability and growth by themselves. If you want to help a person, yes, help him, but in a proper way, in such a way that he can develop for his lifetime. If you want to help for one day, you give food. If you want to help him for 1 year, you sow the rice. Sow the rice. If you want to help him for lifelong, you educate him. You teach him how to earn money, how to live as a good human being. Don't give fish to a beggar. Teach him how to catch the fish. If you give the fish, tomorrow morning he will be back to your house. Every day he will be in front of your house. Those people will be always beggars, and we are the givers. Don't do that one. You teach him how to catch the fish. He has to catch the fish by himself. Leprosy, It is as I told, it is the sister of tuberculosis. It is a chronic disease. It is also known as Hansen's disease because in 1873, Hansen was the person, he was the scientist who, from Norway, I think, Norway. He has identified the cause for this leprosy as Mycobacterium leprae. Prior to that, there are so many thoughts, so many ideas, so many histories. They thought whatever they like, but it is having no proof. It was in 1873, the great gentleman Hansen has identified this Mycobacterium leprae in the skin scrapings of these leprosy patients. And because of this disease was named after him, Hansen's disease. The medical faculty, the medical people, the medical professionals, paramedicals, we should talk it as Hansen's because of the stigma the disease has got. The stigma, even now, it is having some stigma. We have to rule out this stigma. It mainly involves the peripheral nerves. It is not a respiratory disease. It involves the nervous system, that to peripheral nerves. It also affects skin, muscles, eyes, bones, testis, there is spelling mistake, testis, and internal organs also. Mainly the skin is involved. Skin is involved. Once the skin is involved, the peripheral nerve endings, they are affected and it will be carried to the trunk of the nerve and the nerve will be paralyzed. The blood supply will be stopped for that and you will get all the deformities. So first the skin is involved. The clinical features of leprosy. As I am telling this one, the clinical features, I am reminded of a small bit from a well-known Telugu play, that is Rakta Kanneeru by Nagabhushanam. In the good olden days, they thought that this leprosy might be due to the sin what they have done in the previous life. But that is suffering in this life, in this era. And later, some of the people thought that it is a sexually transmitted disease. The hero in that, in Rakta Kanneeru, Mr. Gopalan, he is having leprosy with claw hands and everything. It is clear-cut case of leprosy. He comes to a house and begs for water. Then the kind-hearted woman soothes him. She asks, "What is your disease? From what you are suffering?" Then he tells. It is quite evident if we call, I do not call a community, some community person ending with that name and asking him his caste, how will it be? Any caste. The name is ending with his caste name. If we ask him to which caste you belong, like that, the diagnosis of leprosy is quite evident on the face. Anybody can diagnose the leprosy. The clinical features, hypopigmented patches over the skin. The patch will be hypopigmented, paler in color. Hypopigmented patch will be there. This is the crutch of the problem for leprosy. These patches may be anywhere on the body, anywhere over the body. The patches which are evident on the visible parts of the body, we can see. We have to examine them in good daylight. Thoroughly examine the skin, not excluding any part of the skin. But due to our customs and culture, many people will not accept to be seen in good light or in the hidden parts. Especially all the leprosy staff, most of them, the non-medical assistants, the non-medical supervisors, NMA, NMS, like this, all of them almost for the before 10 years, all are males only, males and graduates, science graduates. Those are science graduates and males. But nowadays, the ladies are also coming because they have, because of this stigma, previously ladies have not entered into this one. As all of them are males, some of the patches or the hidden parts of the body of the females, it was not seen and the case was not detected early. That's why now this has been mixed in the general healthcare system, and all the ASHAs were given training, all the ANMs were given training, multi-purpose health, they are converted into, ANMs are converted into multi-purpose health workers or multi-purpose health assistants. And by this, they thought that we can identify and we can detect the leprosy as early as possible. That is the only mantra, that is the only solution to eliminate leprosy. Early detection of the case, early case detection is the only solution. Hypopigmented patch, and then partial or total loss of cutaneous sensations in the affected areas. Cutaneous sensations, sensation of cold, sensation of heat, sensation of touch, sensation of pain, all these are maybe partially or complete loss. Because of this, they do not know that they are touching a hot object while cooking. Their body part is coming in contact with a thorn. It is not having any pain. That's why these people will get injured. And the peripheries, the feet, the hands, those are injured much. And then presence of thickened nerves. If you see, if you feel the nerves, the ulnar nerve, the median nerve, the lateral popliteal nerve, all these nerves, or even peroneal nerve, all these things, if you feel, there is thickening of these nerves. You have to feel it. Presence of thickened nerves. The nerves, because as I have told earlier, it starts in the periphery, end of the nerve, any nerve endings, and it travels to the trunk. In the meanwhile, the trunk of the nerve is thickened. And then presence of acid-fast bacilli in the skin as well as nasal smears. Acid-fast bacilli. Tuberculosis also same thing. In the skin scrapings, where there is a patch, if we scrape that skin and subject it to microscopic examination under Gill-Nielsen technique, then you can see the acid-fast bacilli. Similarly, the nasal smears also show this one. Nodules in the skin of face, mainly face, that is more attractive towards face. Ears, ear lobules, plantar ulcers. There may be nodules in the ears, plantar ulcers or face. And loss of fingers or toes. You are seeing the beggars, the people begging what is this, signals, center signals. When we stop our car or two-wheeler or anything, that the people will come and beg for the amount. Those people are not having fingers. What happened to those fingers? Is it amputation? No. It is autodigestion. Autodigestion, the term called autodigestion. It is digested automatically by itself. It is not amputation. Loss of fingers or toes, mainly fingers and toes. Foot drop, The person will be walking with the foot drop. He drags his foot on the road while he is walking, foot drop. And in the same way, claw hand, like that, claw hand. The hand will be like this, the claw hand. The extension of the metacarpophalangeal joint is failed. The extension of the interphalangeal joints, first joint, these are failed. These become flexors, like that. And this will be the claw hand. All these are the clinical features of leprosy. Please mind it. The clear-cut, evident person with the nodules, lobules, the thickening, tuberculosis, like that, he is not infective if he is cured, if he has taken treatment. The people whom we are seeing, those are not patients. Those are cured patients. But who is dangerous is the person who is looking like normal, but having a small patch over the skin, which he also neglects. He thinks that it is some skin disease. When this hypopigmented, hypoaesthetic or patch over the skin, that person is more dangerous, and that person is the responsible person for the spread of the leprosy. You see this girl, Avish. We think that she is normal, but if you see here, there is a patch. But please mind it, every patch is not leprosy. If we say the horse is having 4 legs, the horse will have 4 legs. All the animals that are having 4 legs are not horses. That may be fungal infection, that may be hypovitaminosis, that may be something differential diagnosis we have to do. And here the patch is hypoaesthetic. The sensation will be lost. For that, you must know the technique of how to test the sensation, how to test for touch, how to test for heat, how to test for tactile sensation, how to test for pain. All these things you must be familiar. The clinical knowledge, the examination, you must be aware of it. Leprosy spectrum. This is paucibacillary, intermediate, and multibacillary. It is there. Once upon a time, it was single nodule, single patch. That was also considered. Single patch, single day treatment, single dose, like that. But now it has been removed. It is mainly 2 varieties. That is paucibacillary and multibacillary. If the cell-mediated immunity is increased, or is the humoral immunity, this depends upon this, whether the person goes to paucibacillary or multibacillary. See the patches. She is not normal. She is the patient. See this one. The tuberculosis. How? Why these are coming? When the leprosy enter into the skin, the immune cells, our immune cells, they will engulf this one. They will surround this one and form a tubercle. Those tubercles we are seeing. In a person who is having good immunity, this will happen. The immune cells which are present in our body, they will surround this Mycobacterium leprae such that it will not spread to the inner side of the body, and it will become a tubercle-like appearance. See this woman. She has got depression of the nasal bridge. The septum, nasal septum is destroyed. Then the palate is destroyed. Nasal septum and palate. The eyebrows, those are lost. She lost her eyebrows. You see the fingers. See, the face itself is lioniid-like face. If we go to the history of this leprosy, leper is a Greek word which means scaly. The patches over the skin, those are scaly in nature, scaly. The word leper came from the word scaly. Leprosy is known since ancient times, thousands and thousands of years back it was there. In local language, it is called kustu. Kustu. It is having a very ancient history. Even if somebody wants to scold another person, he will curse the person like that. You will get kustu like that. You will get leprosy like that. The kustu. It is also known as kusturoga in Indian literacy and attributed to the curse of God. Curse of God. Hansen of Norway discovered Mycobacterium leprae in 1873. Hansen of Norway. He has discovered his Mycobacterium leprae. Actually, he was seeing for something else in the microscope. Then he found the brownish colored, rod-shaped organisms. The brownish color, as the Mycobacterium leprae take the iron, this brownish color has come. By that clue, he has worked on that and has discovered Mycobacterium leprae. Introduction of sulfones, dapsone, sulfone drugs, dapsone, in the treatment of leprosy in 1943. 1943 marked the beginning of new era. Before 1943, there was no treatment. That is socially eliminated, outcasted like that. But in 1943, the sulfones were discovered, and then at that time, 1942, 43 to 80s, I think 80s, for 40 years nearly, they have given only dapsone till life, lifelong dapsone, lifelong. But later, 1971, Kirschmer from USA has reported the armadillos, the foot pads of armadillos only can grow these Mycobacterium leprae. And mice, the other animals, they can't, we cannot culture that one. Disseminated leprosy when Mycobacterium leprae injected experimentally, armadillos. In 1980, shift of dapsone monotherapy to multi-drug therapy due to dapsone-resistant strains of Mycobacterium leprae. In 1980, that is 40 years back, then the discovery of rifampicin and all this chlorphomazine, this have come, and people use it to develop resistance to dapsone. People use it to develop resistance to dapsone monotherapy. Then they have shifted to multi-drug therapy. This multi-drug therapy in leprosy, this multi-drug therapy, MDT, it showed, it has given a path even for tuberculosis, even for HIV. Multi-drug therapy has introduced in those diseases also with this invention of this leprosy, MDT for the treatment of leprosy. This is the root cause. See how her fingers are. This is called auto-digestion. Don't say it is amputation of the fingers. It is not amputation. It is auto-digestion. Problem statement. If you see the world, in the world, the prevalence increased from 8.4 cases per 10,000 population in 66. If you see in 1966, it was 8.4 per 10,000 population. 8.4 per 10,000 population. It has risen to 12 per 10,000 population in 1985. Why it has risen? In 66, the dapsone has come. We are giving monotherapy. We are giving therapy, treatment for that. Even then, from 8.4, it has risen up to 12% because case detection has come. Reporting has come. The people used to examine them and report them. That's why 8.4 has risen to 12%. It is not that the cases have increased, but the report has increased. So it is not only the figures we have to see, it is the cause for the rise also we have to see. Since then, there is a gradual decrease due to improvement in the management of the cases. Very low rate for relapses. Relapses are very less. High cure rates. It is highly curable. Absence of drug resistance. Shorter duration of MDT with MDT. With MDT, for paucibacillary, it is only for 6 months. For multibacillary, it is 24 months. Previously, they used to take lifelong dapsone. That has come down to shorter duration with MDT. In 1985, 122 countries, 122 is the lucky number, 122 people have passed from your batch. 122 countries were considered endemic. 122 countries, they are endemic for leprosy. At the end of 2000, the leprosy was a public health problem only in 10 countries. See how much improvement you have got. Only in 10 countries, from 122 countries to 10 countries. It is the effort of the doctors. That is we means our ancestors, our brothers, our parents, our fathers, like that. Today, the highest burden is concentrated in 6 countries. Highest concentration, highest burden, it is there in 6 countries. What are those countries? India, our great India. Brazil, Myanmar, Madagascar, Nepal, and Mozambique. These are the 6 countries where the problem is very high. 6 countries where the leprosy problem is very high. We are thinking that leprosy has gone. We are of the opinion that we have eliminated leprosy. No, it is coming back. It has come back, which was the 0.67 per 10,000 population has been, now it has been raised to more than 1. Again, the surveys has to be taken up. Again, we have to concentrate on leprosy, thinking that it has been eliminated. We have neglected the disease. We have removed that leprosy, almost the department, that is amalgamating all the employees to the other departments. There is no leprosy employee now. For that, we are paying the penalty. Now the cases are increased. If anybody is interested, we can do a survey on that. And it is more than 1 per 10,000, which has crossed the elimination limit in India. See, leprosy prevalence in 2000. See, this in one area, that is India and South America, Africa, and all these, in these countries, it is there. WHO global strategy. The World Health Organization has a global strategy for leprosy. It is to reduce the leprosy burden and sustaining leprosy elimination activity. Sustaining, that is most important. To reduce the burden, yes, we have to reduce the burden. We have to cut it short. And then, don't neglect it. Do the sustaining leprosy elimination. You have studied for examinations. Well, you are very good students. You have studied. Don't stop it. You have to continue your study. As soon as you pass the subject, don't put the books away. You have to continue your education. Any doctor, for that matter, all doctors must be lifelong learners. Lifelong learners. Till we go to the graveyard, we have to study. If once you stop learning, Once you stop studying, then the doctor inside your name is dead. The doctor inside you is dead. Please, I am very, I think you may dislike me, but it is the system. It is not for your sake. It is for the sake of the patients who are coming to you. The people who are having belief on you come to you. For their sake, you have to update your knowledge. You have to continue your education. You have to continue your learning. Learning means not only the theory, the skills, everything. You have to continue. Don't stop as the exams are over. You are relaxing in the houses. No, don't relax. Now you are a rishi, maharshi. You are a very good person. You are given a job. The God has searched for the people whom to select for doctors. He thought that you are the best person. He has given you this profession. He has given you the profession, not your parents. He has chosen you, not yourself. You have not chosen the profession. You have not chosen the medical profession. The God has chosen you to be fit for that profession. Please keep up His word. Keep up the word of the God and do justice for that by continuing education. Whenever, wherever you be in touch with the subject, you learn the subject. Even 80 years aged doctors also, they will come for continuing medical education, and they will learn the subject. If the medicine is an ocean, if the medicine is an ocean, we know, I know only 1,000th of a drop of the water in that ocean. I know only 1,000th of a drop, a single drop of water in that ocean. Please imagine how much is there to learn. Don't think that passing the examination or passing in first class or passing in distinction, they denotes that you are a completed doctor. Okay. Sustaining leprosy elimination. Use case detection as the main indicator to monitor the progress. To monitor the progress, the WHO, World Health Organization, has given the case detection as the main indicator. Case detection. How many cases we are detecting in the existing? How much percentage of the cases? How many we are leaving? If we leave the person untreated, to how many people he will spread? The society will be destroyed. The society, the community will be infected. So the early detection, the case detection is the main indicator for monitoring the progress. It is not the curation. It is the case detection. Ensure high quality diagnosis. Diagnosis. What is diagnosis? Diagnosis. Gnosis means knowledge. Dia means through. Through the knowledge. Through the knowledge, you are identifying the disease by the signs and symptoms presented by the patient. Dialysis, diabetes, diabetes, like that. Gnosis, knowledge. Through this, through the knowledge what you have got by learning in the medical college, learning by yourself, learning in the society, learning in the community, learning by net, all these things, you are identifying the disease by the signs and symptoms presented by the patient. That is diagnosis. Prognosis means, pro means in advance, gnosis means knowledge. Through the knowledge what you have acquired by studying the natural history of the disease. All the diseases you are studying the natural history. What will happen for this? If you treat, if you do surgery like that, you are studying. By that knowledge, you are telling in advance what will happen in the future. Yes, there is 70% possibility. Yes, there is 90% possibility. There is only 50% chance to live. Like that you are telling. That is called prognosis. In advance, you are telling the what is happening in the future. So, high quality diagnosis. A good clinician, a good doctor is one who diagnoses the case and treats. Vice versa, many of the medical professionals, if they don't diagnose and throw some 10 stones. Any one stone will strike that one, strike the disease, and it will be cured. He's not a good doctor. He's not a good clinician. Out of the 10, one might be curing this disease, but the remaining 9, they will cause side effects to the other organs. We have no right to destroy the health of the people. If at all you can do, help the people. If you can't do it, keep quiet, but don't harm the patient. Case management, quality diagnosis, case management, how to manage the case, and recording and reporting in all endemic communities. Here, you please, when coming to the diagnosis, as a doctor, we are having 5 responsibilities while treating the patients, while treating a person. Even a healthy person also comes to us. Number 1 is prevention of the disease. At the back of your mind, every minute, every second, it should strike. We have to prevent the disease. If the diseases are more, our purse will be full. Don't think like that. If you concentrate on prevention, automatically the practice will come to you. The people will think that you are their person and you are a good person. The practice will improve. Prevention. Number 2, promotion of health by giving good nutritional education. Number 3, diagnosis. The correct diagnosis. You see how many in the OP register, how many people are writing the diagnosis. You write. Start with you. The change should come with you. It should start with you. When you are given 45 minutes of time in the examination, why don't you spare that time for the patient afterwards also, after the exam? Within 2 minutes, you can't judge. So diagnosis. Number 4, treatment, curation. That is most important, curation. Number 5, the most important is rehabilitation. Rehabilitation, that none of us are concentrating. As the patient comes to us, we must bring him back. We must get him back to the person who was, how he was before getting the disease. Economically, socially, medically, physically, psychologically, on all the grounds. Vocationally, the rehabilitation. Out of these 5, we are concentrating on only treatment, which is not correct. If you concentrate on these 5 grounds, then you will be treated like a god. I'm sure, I'm giving the word, you will be treated like a god. You prepare for that, because it is the initial stage for you. If you bend your mind, if you set your mind like that from now, you can become God of gods. You can become God of gods. Please bear it in mind. Reporting in all the endemic. Strengthen the routine and referral services. Strengthen the routine and referral services. Discontinue the campaign approach. Campaign approach. If you put a camp, a tent, and ask all the people to come there, how can they show their patch or the buttock? How can they show their patch on the back of this one? Or over the mammal area? Or over the private parts? So, discontinue the campaign approach. It is one-to-one individual. Confidentiality must be maintained. The doctor should maintain confidentiality. Develop tools and procedures that are community-based. You must develop the tools and procedures which are community-based, integrated, that should have integration, and locally appropriate for the prevention of disabilities. Disability prevention, that is most important. Promote the operational research in order to improve implementation of the sustainable strategy. Encourage the supportive working arrangements with partners at all levels. Then problem statement in India. Leprosy is widely prevalent in India. India is not leprosy free. As on March 2004, the prevalence rate was 2.4 cases per 10,000 population. That means 24 per 1 lakh. If you are having 1 lakh population, there are 24 cases. In 1981, it was 57 per 10,000, 570. 57 per 10,000 means per 1 lakh it is 570. If you take 1 lakh population or a town of 1 lakh population, in 1981, there were 570 patients. But due to the efforts of the great people, the paramedics also, the non-medical assistants and the non-medical supervisors who are the science graduates and who have sacrificed their life in the giving the pulse treatment. Pulse treatment means they go to the, according to a plan, to the villages early in the early morning by 6. They reach the village by bicycle, and there they put these drugs into the mouth of the patient, and like that they have sacrificed their life like anything. For that they are paid also with good future and good children. Their children are at a very good position because of the service they have rendered towards the leprosy patients. It is the work of the paramedics and the doctors working in the leprosy. From 570, it has brought down to 24. You imagine how much difficult it is. From 570 to 24 within a span of 20 years, 24 or 25 years. Now, as per records, it is 0.67 per 10,000 population. 0.67. That is, for 1 lakh, it is 7 cases. If you take Vijayawada, it is 10 lakh population. That is 67 to 70 cases are there. Here, you must remember, it is not all the cases which we are seeing as leprosy with deformities and disabilities. It is the new cases occurring. That is 6.7 per 10,000 population. As it is less than 1 per 10,000 population, we have declared it as eliminated. Here, another point you must remember. India has achieved elimination. That means the total population of 130 crores, if you calculate, it is less than 1. That is 1,30,000 cases. 1,30,000 cases. But what we have to think as intelligent persons, as a cream of the society, it is the average of the total, all the states, total 130 crores of people. Somewhere it may be 0.1, somewhere it may be 2. But the average, it comes to less than 1. We should not take it as granted that we have eliminated. In some village of, I know some from Adilabad, there are only 250 households, 250 houses, 250 families. Out of them, there are 48 cases. 48 cases of leprosy, new cases per year. So, this average, we have to consider there may be pockets of high number of cases and there may be pockets where they have eliminated completely. So please bear it in mind that we should not take the average and think that it has been eliminated. 6 states could achieve elimination of leprosy both at district as well as state level. Namely, Nagaland, Himalaya, Haryana, Nagaland, Haryana, Himachal Pradesh, Meghalaya, Tripura, and Mizoram. 6 sisters, those northeast states. At these places, the states could achieve elimination of leprosy, both at district as well as state level. State average also less than 1%. District average also less than 1%. Now you go ahead, still further. Mandal level, you see. All the mandals are less than 1%, less than 1 per 10,000 population, that is 0.01%. Then go to village level. Micro planning, this is called micro planning. You consider village as a unit and then calculate. Then only it is correct. Now coming to epidemiological triad, is the time sufficient? 10:30. Okay. We will discuss as a triad, that is agent factors, host factors, environment factors. Shall we continue in the next class or? Okay. It is already 10:30. We will complete agent, the agent factors. As all of you know, leprosy is caused by Mycobacterium leprae. Hansen's disease is caused by Mycobacterium leprae. It is acid-fast bacilli seen both intracellularly as well as extracellularly in the host. If you see HIV, it is intracellular. Here, it is both intracellularly as well as extracellular. They characteristically occur in clumps or bundles called globi. These Mycobacterium leprae, these are not single ones. These appear in bundles, group. These occur in, what is this called? Heads, groups. This is called globi. They have affinity for Schwann cells and cells of reticular endothelial system. They remain dormant in various sites and cause relapses. Some sites, they remain dormant for a long period, and that is the reason for the relapse. As they are dormant, we will not take any action. As they are dormant, we will not take any action. So the relapse will occur. Numerous antigens, almost about 20, were detected in Mycobacterium leprae, some of which share with other mycobacteria. There are about 20 types of antigens. Phenolic glycolipid, PGL. Phenolic glycolipid is specific for Mycobacterium leprae antigen. PGL is specific. It is the PG entrance question. Phenolic glycolipid is specific for Mycobacterium leprae antigen. You can see the 200x magnification. Histology, you can see. I think all of you are very well versed. You are more intelligent, more update than me, because you have studied microbiology recently. Here, with your permission, the previously Jahnavi has asked one question, that is why there is evening rise of temperature in tuberculosis. Before I forget, I want to tell. That is the action of the interleukins. Interleukins, as the day advances, they will act more, and that is the action of the interleukins. By that, the evening rise of temperature will be there. I don't want to spare much time on that. We can discuss individually that one. Source of infection. What is the source of infection for leprosy? Generally, multibacillary cases are most important source in the community. Multibacillary. In the classification, we will say how the leprosy is classified. Multibacillary cases are the most important source in the community. In apparent infection, may also from source of infection. inapparent infection may also be from the source of infection. All patients with active leprosy must be considered infectious. All patients with active leprosy, they must be considered as infectious. Generally, we use the words, it is non-infectious. Leprosy is non-infectious. We will tell the family members also, it is not infectious. Please allow him into the house. Treat him like just like the other people. But it is infectious, but it will not come within minutes or days or hours or something like that. It is the prolonged contact, prolonged constant contact with the leprosy patient. The disease will be transmitted to the other person. So prolonged contact. Previously they thought that it was inherent, the hereditary. No, it is not like that. As the child will be with the mother, if the mother is having the leprosy, due to that prolonged contact, the child may get, but it's not inherited. Wild animals involved are armadillos, mangabi, monkeys, and chimpanzees. This is armadillo. I think you have seen armadillo. Portal of exit. What is the portal of exit? Nose is a major portal of exit. Here, it is the disease of the skin, it is the disease of the peripheral nerves, but nose is the portal of exit. Mycobacterium leprae in the nasal mucosa are discharged when they sneeze or blow the nose. While talking, it may not contaminate, but these are dislodged or discharged from the nasal mucosa when the person sneezes forcibly or blows his nose. I think you understand this. The other portals of exit are ulcerated, broken skin. Intact skin will not. Ulcerated, broken skin. It is another portal of exit. Through this, the Mycobacterium leprae comes out of that patient, and one or two contacts, the healthy person will not get it. So, prolonged contact must be there. Sometimes from the intact skin through hair follicles also, it is recorded. The skin may be intact, but through the hair follicles, it may. So what we have to learn? Don't share the combs. Don't share the combs. This is this one. Because the person with leprosy, they will lose the eyebrows hairs. That means this is affecting the follicles, hair follicles. So in that hair follicle, the organism may be there. The skin is intact, but the hair follicle is infectious. So don't share the comb with anybody. The combs are dangerous. See this one. See her nose, see her eyebrows, the nasal bridge, nasal septum, and the palate, all those are destroyed. Infectivity. Leprosy is highly infectious disease, but of low pathogenicity. It is highly infectious. Infectious because the people are afraid. We should not make them frightened. If they are afraid, they won't come. They won't reveal their disease. That will be hidden and that will be spread to the community like anything. So don't make the people afraid. Pathogenicity is less. An infectious patient, it is not an infectious patient, can be rendered non-infectious. If you want to convert an infectious patient to non-infectious, what you do? Treatment with dapsone, it takes 3 months. If he is given dapsone continuously daily for 3 months, the infectious person will become non-infectious. If you give rifampicin for 3 weeks, that person will become non-infectious. With rifampicin, it is only 3 weeks. Rifampicin nasal drops or spray. If you use rifampicin nasal drops or spray for the leprosy patient, within 9 days, the person will become non-infectious. That means as soon as you diagnose a Hansen's patient, then put him on rifampicin nasal drops for 10 days. Put him on rifampicin nasal drops for 10 days. You have saved many people from getting the infection. You have the chance of saving many people from leprosy by just prescribing rifampicin nasal drops for 10 days for the infectious patient. Just a simple. It is not for his sake. It is for the public. And now, the attack rates. Among the household contacts of lepromatous cases, household contacts. Who are the household contacts? Spouse, if the person is male, the wife, the children, and the servant maid, who are very close to that family. Varying proportion of 4 to 12% is expected to show signs of leprosy within 5 years. 4 to 12% are expected to show the signs, but it is not within 1 day. It is not within 1 month. It is not within 1 year. It may take 5 years. It is the incubation period is such a long period. So, households or contacts. That's why what we do, if we detect a case of leprosy, contact survey will do. Household survey will do. Contacts. Who are the contacts? Even now we are doing this contact survey for COVID. Whoever comes and who is positive, who are the contacts for him? First line of contact, second line of contact, like that we are going. So, we will stop at this level. Post factors and the other things we will discuss in the next class. The clinical features and everything, the treatment, the host, environment, diagnosis, clinical features, diagnosis, and treatment. Up to that, we will discuss in the next class. And the national program will be dealt with my colleague. Okay, now let us chart for a few minutes. You want it is, I think the time is over. You want 5 minutes rest? Everybody wants rest. In the charting nobody is here. No. On Friday evening, between 5:30 to 8 p.m. Friday evening, 12th. We are having panel discussion on the topic yesterday, today, and tomorrow, COVID-19. And the panelists are from All India Institute of Medical Sciences, New Delhi, in the Calcutta, public health expert, and some of the head of the departments of the medical colleges, community medicine of the medical colleges in Andhra Pradesh. You can share if you want. I will give the ID and password also. CR, please. I'll give it to you. You chat with me. You can distribute. That will be useful because the knowledge from the AIMS, that will be useful for you. CR, please respond. CR, please respond. Am I audible to you? CR, please. If he's not there, the other alternative, second CR, or anybody from the batch? Anybody from the batch? Yeah. 100. Good morning. I asked you to write the name. We are the persons. We are having name. Don't call by numbers. Devanu, anything you can share in the group? This webinar on Friday. I will give you the link. You can distribute to your friends. You are having my number, I think. It is 944. Write it. 944. Shall I write it? Can it be? 0666991. Okay. This is my WhatsApp number. Put it in your group, and anybody wants this one, they can have. That webinars, they will be very good. Good. Good, Odevanu. As the time, we are lacking of time, the next speaker has also come. I think you need some rest also for 5 minutes. I will stop at this level. Okay, have a good time. Thank you. Kumar? 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 చూడు ఇది ఆపాను కరెక్ట్ కాదు చూడు ఎట్లా చేసి ఏం చేశానో తెలియదు పోలా ఇందాక అసలు క్లాస్లో